Look closely at the top panel, where we have a perfect demonstration of a normal, awake brain. See those beautifully regular, rhythmic waves cruising along at about 9 Hz in the posterior channels? That is your classic alpha rhythm, the posterior dominant rhythm of a relaxed, awake individual with their eyes closed. But watch what happens the exact moment they open their eyes at the EO marker. That alpha rhythm completely vanishes, short-circuiting into low-voltage, fast, chaotic beta activity. This is called alpha blocking or reactivity, and it is the very first thing you check to confirm a healthy, responsive cortex. Now, shift your focus down to the bottom panel, where the patient has drifted off into stage 2 non-REM sleep. The whole landscape shifts. That crisp alpha background drops away, replaced by a much slower, rolling 2 to 5 Hz mixture of theta and delta waves. Right in the middle of this slower background, two fascinating physiological landmarks pop out. First, look at that sharp, diphasic dip marked with a V, right in the midline central channels. That is a vertex-sharp wave, a classic transient of early sleep. Then, scan across the frontocentral leads and you will spot these beautiful, tight bursts of waxing and waning sinusoidal activity humming at around 12 to 14 Hz for just a second or two. Those are sleep spindles, generated by the thalamus gating out the external world. When you spot those spindles, you know with absolute certainty your patient is soundly asleep. Take a look at this tracing, which provides an absolutely classic illustration of an activation procedure inducing a profound cortical reaction. We are monitoring a 31-year-old female, and if you look at the stimulus channel near the bottom, you can track the exact moment intermittent stroboscopic light stimulation is introduced at 13 flashes per second. Watch how the relatively quiet baseline is suddenly, violently disrupted by a high-amplitude, symmetrical burst of generalized 4 to 5 Hz spike wave activity. This is a textbook photoparoxysmal, or photoconvulsive, response. What makes this particular tracing so incredibly valuable for your clinical training is the real-time behavioral mapping recorded right below the channels. Notice the timeline marked with T and P. The technologist delivers an auditory tone, marked as T, to actively test the patient's awareness during the burst. The line failing to step up to P documents the patient's absolute inability to respond, proving that this electrographic discharge is causing a functional, brief absence seizure. Notice how the very instant the flashing stops, the spike wave paroxysm vanishes, her normal responsiveness returns immediately, and the background baseline completely normalizes. This tells you her underlying brain architecture is otherwise healthy, but highly sensitive to specific photic driving frequencies.
This EEG tracing perfectly captures the classic electrographic signature of genetic, idiopathic, generalized epilepsy. Let's break down exactly what is happening across these channels so you can map the waveform morphology to the clinical presentation described in the caption. 1. The montage setup. The labels on the left represent a standard longitudinal bipolar montage, often referred to as a double banana chain. It records the voltage difference between adjacent electrodes from front to back, left hemisphere, R1 F3, frontopolar to frontal, F3 C3, frontal to central, C3 P3, central to parietal, and P3 O1, parietal to occipital. Right hemisphere, R2 F4, F4 C4, C4 P4, and P4 O2. 2. Key electrographic features. Generalized synchrony. Notice how the high amplitude discharges burst into existence at almost the exact same millisecond across all channels. There is no focal onset or localized point of origin. Both hemispheres are recruited simultaneously. Spike wave morphology. Each complex consists of a sharp, high-voltage spike, representing rapid, synchronous neuronal depolarization, immediately followed by a broader slow wave, representing intracellular inhibitory postsynaptic potentials trying to quiet the cortex. Frontal dominance. If you look closely at the amplitude, the height of the waves, the deflections are highest in the frontal regions, R1 F3, F3 C3, R2 F4, F4C4, and taper off slightly as they move posteriorly toward the occipital leads, P301, P402. This anterior dominance is classic for primary generalized epilepsy. 3. Clinical correlation. The calibration bar at the bottom right shows a 1-second time interval and a 75 mu text v amplitude scale. If you count the spike wave complexes within that 1-second window on the right-hand panel, you will find roughly 3 full cycles. This 3 Hz generalized spike and wave pattern is the classic pathognomonic rhythm associated with absence seizures. When these bursts are brief, lasting only a few seconds, the patient experiences those occasional absence attacks mentioned in the figure text, brief staring spells with a sudden pause in consciousness. When these synchronous bursts become more prolonged, unmodulated, or faster, they can easily destabilize the entire cortex, cascading into the generalized tonic-clonic seizures that this patient primarily experiences. In stark contrast to the generalized, symmetrical patterns seen in primary generalized epilepsy, this tracing demonstrates a classic focal, localization-related abnormality. Here is how to systematically read this recording to pinpoint the structural lesion causing this patient's epilepsy. 1. The temporal montage setup. This tracing utilizes a longitudinal bipolar montage focusing on the lateral temporal chains, which run along the outer sides of the head, left temporal chain, top 4 channels, R1 F7, right arrow F7 T3, right arrow T3 T5, right arrow T501. Right temporal chain, bottom 4 channels, R2 F8, right arrow F8 T4, right arrow T4 T6, right arrow T602. Notice that the left hemisphere channels look completely clean, showing normal, low voltage background activity. The pathology is strictly confined to the right hemisphere. 2. Identifying the phase reversal at F8. To localize a focal spike in a bipolar montage, we look for a phase reversal, the visual phenomenon where the waveforms in 2 adjacent channels point toward each other, acting like arrows pointing directly at the source of the electrical current. Look closely at the second and third major sharp discharges in the right hemisphere channels. In channel R2F8, the spike deflects sharply downward. In channel F8T4, the spike deflects sharply upward. Because these 2 deflections move in opposite directions and meet at the shared electrode, F8, it tells us that F8, the right anterior temporal electrode, is the point of maximum electronegativity. This confirms a highly localized, independent right anterior temporal spike focus. 3. Anatomical and clinical correlation. The anatomical localization perfectly mirrors the patient's clinical history. The structural cause: the patient suffered a stroke in the territory of the right middle cerebral artery, MCA. The MCA supplies the lateral surface of the cerebral hemispheres, including the temporal lobe. The ischemic insult left behind a localized scar, gliosis. The epileptogenic zone. The scarred, post-stroke tissue acts as an unstable focus where cortical neurons spontaneously and synchronously fire, generating the interictal spikes captured here. The seizure type. Because the hypersynchrony is confined to the temporal lobe, it manifests clinically as focal impaired awareness seizures, historically termed complex partial seizures, which frequently involve localized automatisms, epigastric auras, or behavioral arrest before potentially spreading. This tracing displays one of the most striking and ominous patterns in clinical electroencephalography, hypsarrhythmia. While the previous EEGs we looked at had clear structural organization, either bursting simultaneously or localizing to a single focus, this recording demonstrates total cortical chaos. 1. Decoding hypsarrhythmia. The term literally translates to mountainous or high rhythm, and this tracing shows exactly why. We can break its features down into 3 main electrographic pillars: extreme voltage, high amplitude. Notice the calibration bar at the bottom right. The scale is set to 150 mu text V, double the voltage scale of the first generalized tracing, 75 mu text V, and triple that of the focal tracing, 50 mu text V. Despite this reduced sensitivity, the waves still dominate the page. Complete disorganization. There is no identifiable, normal background rhythm, such as a posterior dominant rhythm. The normal architecture of awake or asleep cortical activity is entirely replaced by a chaotic, random sea of waves. Multifocal spikes and sharp waves. Sharp, epileptiform discharges are firing constantly, but they are completely asynchronous. You can see a spike focus in the left frontal channels, another independent focus firing a split second later in the right temporal channels, and random slow waves scattering across the posterior leads. 2. Clinical significance, West syndrome. Hypsarrhythmia is the pathognomonic EEG hallmark of West syndrome, a severe, age-specific epilepsy syndrome of infancy. It classically presents as a triad: hypsarrhythmia on EEG. Infantile spasms, sudden, brief flexor or extensor movements, often presenting as jackknife clusters when the infant is waking up or falling asleep. Developmental regression, a plateau or loss of previously acquired motor and social milestones. The 8-mom label at the top center of the tracing stands for 8 months male, which hits the peak age of onset for this condition, typically between 3 and 12 months. 3. Why this pattern is an electrographic emergency. Hypsarrhythmia does not just represent a high seizure burden, it signifies continuous, widespread cortical dysfunction during a critical window of neurodevelopment. This relentless, chaotic electrical storm acts as a massive barrier to normal synaptic plasticity. Because of this, identifying this pattern prompts immediate, aggressive medical intervention, typically utilizing high-dose adrenocorticotropic hormone, ACTH, vigabatrin, or high-dose oral corticosteroids, to rapidly suppress the chaos and rescue the infant's developmental trajectory. This tracing provides a classic, textbook example of an ictal, during seizure, event in childhood absence epilepsy, K. While the first generalized tracing we evaluated showed brief, interictal bursts, this image captures a sustained, high-amplitude paroxysm that directly correlates with clinical symptoms. 1. Anatomy of the paroxysm. We are back to a standard longitudinal bipolar montage, R1F3 down to P402. Abrupt onset and offset. Notice how the normal background activity instantly vanishes on the left, replaced by a massive electrical storm, and then terminates just as abruptly on the right. There is no post-ictal slowing or gradual buildup. It turns on and off like a light switch. Synchrony and symmetry. The discharges occur simultaneously across both hemispheres and look almost identical on the left versus the right, confirming a highly synchronized thalamocortical loop involvement. Frontal maxima. The amplitude of the waveforms is visibly largest in the anterior leads, R1F3, R2F4, compared to the posterior occipital leads, P301, P402. 2. Calculating the frequency. Let's look at the calibration scale at the bottom right, 100 mu, text, V, over a 1-second time interval. If you isolate any single 1-second interval during the run of the seizure and count the number of sharp spike and slow wave complexes, you will count exactly 3 cycles. This rhythmic 3 Hz spike and wave frequency is the pathognomonic hallmark of classic absence, petit mal, seizures. 3. Clinical and physiological correlation. The thalamocortical loop. This 3 Hz rhythm is driven by an abnormal, hypersynchronous oscillation between the cerebral cortex and the thalamus, heavily mediated by low-threshold T-type calcium channels in thalamic neurons. This physiology explains why ethosuximide, a specific T-type calcium channel blocker, is highly effective first-line therapy. The ictal presentation. The caption notes that the specific discharge lasted 12 seconds, during which the 9-year-old boy was unresponsive and demonstrated rhythmic eye blinking. A burst lasting less than 2 to 3 seconds is often subclinical. The patient may not notice it. Once a 3 Hz burst crosses the 3-second threshold, cortical processing is sufficiently disrupted to cause a complete absence of awareness. The rhythmic eye blinking, or minor facial automatisms seen here are common physical manifestations that sync rhythmically with the 3 Hz electrical pacing of the spike wave discharge itself.
Looking at this tracing, we can see a classic, textbook demonstration of generalized polyspike and wave patterns. Notice how the abnormal paroxysmal discharges erupt simultaneously across all channels. This absolute bilateral synchrony and symmetry tells us immediately that we are looking at a generalized network phenomenon rather than a focal onset. Instead of a single spike before the slow wave, you can appreciate rapid bursts of multiple spikes clumped together, which is the electrographic signature highly characteristic of juvenile myoclonic epilepsy. The background activity is abruptly interrupted by these fast, somewhat irregular spike wave complexes, typically firing at a frequency faster than the classic 3, text, Hz, seen in standard absence seizures, usually resting around 3.5, text, Hz, to 6, text, Hz. When you see this precise run of polyspikes on a patient's routine EEG, it correlates beautifully with a clinical history of brief, involuntary morning jerks or generalized tonic-clonic seizures frequently triggered by sleep deprivation.
This tracing provides a classic textbook example of an ictal during seizure event in childhood absence epilepsy, K. While the first generalized tracing we evaluated showed brief, interictal bursts, this image captures a sustained, high-amplitude paroxysm that directly correlates with clinical symptoms. 1. Anatomy of the paroxysm. We are back to a standard longitudinal bipolar montage, R1F3 down to P402. Abrupt onset and offset. Notice how the normal background activity instantly vanishes on the left, replaced by a massive electrical storm, and then terminates just as abruptly on the right. There is no post-ictal slowing or gradual buildup. It turns on and off like a light switch. Synchrony and symmetry. The discharges occur simultaneously across both hemispheres and look almost identical on the left versus the right, confirming a highly synchronized thalamocortical loop involvement. Frontal maxima. The amplitude of the waveforms is visibly largest in the anterior leads, R1F3, R2F4, compared to the posterior occipital leads, P301, P402. 2. Calculating the frequency. Let's look at the calibration scale at the bottom right, 100 mu, text, V, over a 1 second time interval. If you isolate any single 1 second interval during the run of the seizure and count the number of sharp spike and slow wave complexes, you will count exactly 3 cycles. This rhythmic 3 Hz spike and wave frequency is the pathognomonic hallmark of classic absence, petit mal, seizures. 3. Clinical and physiological correlation. The thalamocortical loop. This 3 Hz rhythm is driven by an abnormal, hypersynchronous oscillation between the cerebral cortex and the thalamus, heavily mediated by low-threshold T-type calcium channels in thalamic neurons. This physiology explains why ethosuximide, a specific T-type calcium channel blocker, is highly effective first-line therapy. The ictal presentation. The caption notes that this specific discharge lasted 12 seconds, during which the 9-year-old boy was unresponsive and demonstrated rhythmic eye blinking. A burst lasting less than 2 to 3 seconds is often subclinical. The patient may not notice it. Once a 3 Hz burst crosses the 3-second threshold, cortical processing is sufficiently disrupted to cause a complete absence of awareness. The rhythmic eye blinking or minor facial automatisms seen here are common physical manifestations that sync rhythmically with the 3 Hz electrical pacing of the spike wave discharge itself. This electroencephalogram, EEG, demonstrates the classic neurophysiological hallmark of benign Rolandic epilepsy, BRE, also known as benign epilepsy with centrotemporal spikes, BECTS. Here is a clinical breakdown of what is happening in this tracing. 1. The core waveform pathology. The image captures stereotypical diphasic or triphasic sharp waves, centrotemporal spikes. These are high-voltage, brief disruptions to the background rhythm. Notice how they characteristically have a sharp, rapid initial deflection followed by a slower wave, often presenting with a prominent negative peak. 2. Anatomic localization, anterior-posterior bipolar montage. By analyzing the channels, we can localize the maximal electronegativity of the discharge. The caption notes localization to the right central parietal and midtemporal regions. If we look closely at the right-sided channels, indicated by even numbers, F4C4 and C4P4, show distinct, sharp phase reversals and sharp transients. F8T4 and T4T6 show prominent, sharp spikes in the midtemporal region, T4. The phase reversal, where the spikes point toward each other across adjacent channels sharing a common electrode, helps localize the exact focus to the centrotemporal, Rolandic, Fisher region. 3. State activation, drowsiness and sleep. The clinical note mentions this trace was obtained during drowsiness. This is a classic behavioral feature of BECTS. While these spikes can occur during wakefulness, their frequency and abundance characteristically increase dramatically during non-REM sleep and drowsiness, sometimes appearing in bilateral synchronous bursts or shifting from side to side. This case demonstrates how a structural focal lesion, specifically a high-grade tumor like a glioblastoma, directly alters both macroanatomical structures and localized neurophysiology. 1. Neuroimaging findings, CT scan, image A. The non-contrast computed tomography, CT, axial slice reveals a massive structural pathology in the right hemisphere. Remember, by radiological convention, the left side of the image represents the right side of the patient's brain, the lesion. There is a large, complex, hypodense, dark area involving the right temporal and parietal lobes. This hypodensity represents a combination of necrotic tumor core, cystic components, and surrounding vasogenic edema. Mass effect. The lesion exerts significant mass effect, leading to the compression and partial effacement of the right lateral ventricle, along with a distinct midline shift toward the left. 2. EEG findings and focal correlates. EEG trace, Image B. The longitudinal bipolar montage beautifully maps the physiological disruption caused by the tumor and its surrounding edema. The normal background rhythm is lost over the affected areas, replaced by two classic pathological hallmarks: a focal polymorphic delta activity, PDA. Look closely at the right hemisphere channels, specifically the right temporoparieto-occipital regions, C4P4, P4O2, F8T4, T4T6, and T6O2. These channels show continuous, arrhythmic, polymorphic, slowing in the delta range, less than 4, text, Hz. Irregular, high-voltage slow waves replace normal rhythms. This specific pattern of focal PDA is a classic indicator of structural white matter disruption, typically caused by underlying tumors, abscesses, or focal infarcts. B. Asymmetry and loss of normal background, alpha rhythm. If you contrast the right hemisphere with the left, you'll see a profound asymmetry. Left hemisphere, R1F3, F3C3, C3P3, P3O1, show a marked loss of the normal posterior dominant alpha rhythm. Instead, the left hemisphere displays overriding, low-voltage faster frequencies, beta activity. The clinical sign: this attenuation or loss of the normal background rhythm over an entire hemisphere usually indicates widespread cortical dysfunction or a disruption in the thalamocortical lobes responsible for generating normal alpha rhythms, heavily driven here by the massive right-sided mass effect and increased intracranial pressure. This EEG tracing highlights an important electrographic pattern seen in generalized epilepsy syndromes: intermittent rhythmic delta activity, IRDA, acting here as a non-specific marker of underlying cortical hyperexcitability. 1. Analysis of the waveform, rhythmic delta bursts. The tracing captures a sudden, prominent burst of high-voltage, rhythmic activity lasting approximately 2 to 3 seconds before resolving back into a lower amplitude background. Frequency. The waves within the burst occur at a frequency of roughly 2, text, to 2.5, text, Hz, placing them squarely in the delta band, less than 4, text, Hz. Morphology. Unlike the polymorphic, continuous slowing caused by structural lesions, like the glioblastoma in the previous case, these waves are highly rhythmic, sinusoidal, and monomorphic. They look uniform from one wave to the next. 2. Spatial distribution. Frontal dominance, FIRDA. Looking closely at the longitudinal bipolar channels, the burst is not localized to a single focal spot, nor is it completely uniform across the entire head. Bilateral and synchronous. The bursts appear simultaneously in both the left hemisphere, R1F3, F3C3, and the right hemisphere, R2F4, F4C4. Anterior to posterior gradient. The amplitude of these slow waves is highest in the frontopolar and frontal channels, R1, R2, F3, F4, and rapidly attenuates as you move posteriorly toward the parietal and occipital channels, P3O1, P4O2. This classic presentation is known as FIRDA, frontal intermittent rhythmic delta activity. In adult patients, intermittent rhythmic delta activity characteristically manifests with this frontal predominance. 3. Clinical significance in primary generalized epilepsy. While historically associated mainly with deep midline structural lesions or increased intracranial pressure, synchronous IRDA is frequently encountered as a nonspecific projection of diffuse encephalopathy or generalized genetic, idiopathic epilepsies. The pathophysiological link. The rhythmicity and bilateral synchrony of FIRDA suggest it is generated by abnormal oscillations within the deeper thalamocortical loops, the same networks responsible for generating generalized spike and wave discharges. Diagnostic context. As the caption notes, generalized spike wave activity occurs elsewhere in this patient's recording. This frontal delta bursting serves as an interictal marker reflecting a generalized, unstable cortex predisposed to tonic-clonic seizures. This EEG tracing illustrates one of the most classic and distinctive patterns in clinical neurophysiology: triphasic waves secondary to hepatic encephalopathy. While historically considered pathognomonic for hepatic failure, these waveforms are more broadly recognized today as a classic signature of severe metabolic encephalopathy, including uremia, severe electrolyte imbalances, or anoxia. 1. Morphology of a triphasic wave. If you isolate a single complex within this burst, you can trace three distinct phases that give the waveform its name. Phase 1, initial negative, a small, brief upward, negative, deflection. Phase 2, main positive, a prominent, high-voltage downward, positive, deflection. This is the dominant component of the complex. Phase 3, subsequent negative, a slower, upward, negative, deflection that often tapers off into a slow wave. The background rhythm between these bursts is diffusely slowed, reflecting a generalized metabolic depression of the central nervous system. 2. Spatial and temporal characteristics. Triphasic waves possess highly specific spatial and timing criteria that distinguish them from focal or epileptiform activity, bilateral synchrony and frontal dominance. The waves occur symmetrically across both hemispheres at the same time. Looking at the longitudinal channels, the amplitude is highest in the anterior regions, F3C3, F4C4, and gradually diminishes as it travels toward the posterior occipital regions, P301, P402. The frontal to occipital time lag. If you look closely down a vertical plane at the peak of a single positive wave, phase 2, the peak in the frontal channels occurs slightly earlier than it does in the occipital channels. This characteristic antero-posterior phase shift, a time lag of roughly 20 to 100 milliseconds from front to back, is a classic hallmark of metabolic triphasic waves. 3. Pathophysiology. The rhythmicity, synchrony, and front-to-back migration of triphasic waves strongly point to a disruption in thalamocortical circuitry. In the setting of hepatic failure, the accumulation of neurotoxins, most notably ammonia, alters astrocytic function, disrupts glutamate and GABA neurotransmitter pathways, and impairs metabolic support to cortical neurons. This diffuse metabolic stress desynchronizes normal thalamocortical oscillations, causing the characteristic slow, rhythmic, triphasic bursts seen here.